Most people who get their cholesterol checked assume that they're in the clear. However, this study shows that those with low or even normal LDL cholesterol can have a hidden heart risk. So in this presentation today, I'm going to go through what is ApoB, what is LDL cholesterol, what did the study actually show, what affects your ApoB, and then things that you can do going forward to affect that. So starting off, what is ApoB? So ApoB is a protein which is attached to cholesterol carrying particles that normally go from the liver to the body. So as you can see, it's attached to these three main ones that we're interested in, which is very low density lipoprotein, intermediate density lipoprotein, and low density lipoprotein. The main thing to consider is that all ApoB labels, for example, are the same weight and size so that we can then calculate them accurately. The biggest difference with ApoB is that it reflects a particle number. So the best way to describe this is that if you had 40 taxi drivers at a rank and you wanted to know the chance of you getting a taxi. Now, if each of them taxi drivers have their own taxi, there's a higher chance of you getting one on the night. However, if out of them 40 taxi drivers, they pair up, so there's only 20 taxis available, then you have a lower risk of getting it. And that's the same when it comes to cholesterol within the arteries. You could have the same amount in terms of cholesterol concentration. However, knowing the amount of particles that it's in will then determine how many times it will collide and interfere with the artery wall, which will then lead to the plaques that develop into heart attacks and strokes. And a big thing as well is that ApoB is accurately measured, whereas other lab values in the cholesterol profile are usually calculated via an equation. So it's not a true reflection of what's going on. Now, when it comes to LDL cholesterol, like I said, it is a subset, as you've seen before, of cholesterol carrying particles that go from the liver to the periphery, so to other tissues. However, it is only one of the subset of particles, whereas ApoB encompasses all of them. So that is where one of the benefits of ApoB is that it's a true reflection of all particles carrying cholesterol away from the liver. Another difference is that it is a concentration, and like I said before, it doesn't tell you how many particles that's in. So if you use this jug of water, let's say it's got 2 liters of water in. Now, if you were to put that in glasses, dependent on how much you put into each glass, will determine how many glasses that you can get out of that 2 liters. So it's good to actually know the value, but it's better to know how many particles there are containing cholesterol. And like I said, it is estimated. So it uses something called the Friedewald equation, which uses other lipids within your blood panel. And then we can determine from that what the likelihood is that your cholesterol concentration is within low density lipoproteins. So in the UK and Europe, well, Europe is actually shifting more towards ApoB, but definitely in the UK, we still use low density lipoprotein cholesterol, historically known as bad cholesterol, which a lot of people will refer to. But ApoB has had a lot of evidence for such a long time. And the study that I've gone through today, I will put in the notes so you can go over it yourself. But this study followed over 2,700 men and women, both with white and black background, over 25 years. What it did show is that those with a high ApoB and with a low LDL cholesterol, that there was a 55% chance that they would go on to have a coronary artery calcification. So what does that mean? When you have calcium within your arteries, especially around the heart, it shows advanced heart disease at that one particular part. So this is why we use a coronary artery calcification score, which is known as a CAC. In those who had high levels of ApoB but low to normal LDL cholesterol, they still had a 55% increased risk of having some calcification when they were then reassessed 25 years down the line. If you were to just go off your LDL cholesterol values normally, there would be no intervention from a medical point of view. We would have just left it in the UK, for example. Whereas if you actually look at it from an ApoB point of view, it would require intervention and helping to navigate away from calcification, which if you have too much calcification in the future, it reduces blood flow to the heart. Depending on which artery it affects will reduce blood flow to that particular organ or tissue, which can then lead to stroke, heart attack, etc. When you compare that to a group who had high ApoB, high low density lipoprotein cholesterol, there was a 94% chance that you would have some form of calcification after 25 years. Whereas if you'd done the inverse, so if you had a low ApoB and high LDL cholesterol, there was no statistical significance, meaning that ApoB here is the dominant biomarker. Like with all studies, there are limitations. So using calcium within the arteries as a surrogate marker, meaning using that to assess heart disease, it could be underrepresenting the significance of ApoB because, like I said before, to have calcification in your artery, it needs to be really advanced at that point. Whereas we could have used other endpoints, whether that be chest pain, it could have been high blood pressure, etc. The population studied was 18 to 30 years old. They were then followed up on average 25 years later. How does this correlate if you were to then start in your 50s and review when you are 75, 80? Again, we can't extrapolate it fully, but we can have a good idea that you will have some benefit if we lower ApoB. And the baseline population were obese in 11.4% of people, and 27% of them were smoking. So whether that had a big part to play, which more than likely it did in terms of disease progression with heart conditions, calcification. But with all studies, there have to be some limitations, and sadly, these were the ones there. But going on to what affects ApoB. So let's start with insulin resistance. If you cannot use insulin throughout the body, downstream through a complex cascade, it will lead to the fact that your body cannot metabolize fats from the blood. And then this means that you have more fats accumulating within the blood longer term. And the fats that accumulate within the blood usually do so in particles such as VLDL and LDL cholesterol particles, meaning that your ApoB will go up in this instance. When it comes to saturated fat, high saturated fat increases the production of VLDL and LDL particles from the liver, but also decreases their uptake from the blood. So again, this will also increase ApoB. Now, carbohydrates, a lot of people may be aware of the fact that if you have excessive carbohydrates and you don't utilize them, then they will go to fat. Again, like the same process as above, if you've got an increased amount of fat being output by the liver, it will be increasing ApoB. So this leads on to what should you do going forward to reduce your risk. The first one is to test your ApoB. Now, in the UK, this is not routinely offered, and I think in a lot of health systems across the world, ApoB does not form part of the routine blood panel. So you may need to go through that privately. Like I said, this is not a plug, but we do that in our clinic. One thing I would do that everyone can have access to is increasing their amount of exercise. So if you improve lean mass, whether that be through weightlifting or by general weight loss, and then also increasing aerobic activity, these both together compound to increase insulin sensitivity. If you increase insulin sensitivity, you would then increase the utilization of carbohydrates and fats throughout the body, which then reduces your ApoB overall. And then lastly, improving your diet. So if you reduce the amount of saturated fat, you will then have a reduced output from the liver and increased uptake. If you then reduce the amount of refined carbohydrates in general, but refined because they have a quicker onset, then again, you will reduce your ApoB by the mechanisms we've said before, but also by increasing the amount of fiber, aiming for 30 grams a day, give or take, increasing the amount of fermented foods and polyunsaturated fats. All of these combined will help balance all the vitamins, minerals, nutrients within the body to help all of the processes that would have been affected by a poor diet. Now, this is the first of a few videos that I'm going to do on blood and biomarkers going forward, and just trying to put it into relatable terms, use studies so that people can actually see what I'm citing and what I'm going from. But this is what I'm doing at the moment, testing my ApoB, increasing the amount of aerobic activity, trying to improve muscle mass, and diet has always been a fundamental part anyway, so I'll keep doing that going forward. And as always, thanks for watching, and hopefully you've taken something from the video.